So we'll move on to the next talk before lunch. The next talk is about cardiac sarcoidosis, and I'm going to just set the stage with a brief case followed by Dr. Mouaz Al-Mallah, who's the director for our cardiac PET program and imaging guru, well published, well recognized. He's recruited here recently to open up our cardiac PET panel. Thanks, Mouaz, for doing this. So we'll start quickly just to set the stage. These are my disclosures. So sarcoidosis, the reason why we want to talk about cardiac sarcoid specifically is it's an elusive disease. It gets missed more often than not. But the basics of sarcoid, that there's a lot of unknown. It's a chronic inflammatory disease, and there are multiple factors that we think contribute to it as an insult, followed by some genetic predisposition. And then there are a lot of epidemiological studies that associate multiple factors, essentially leading to a granuloma formation. So the biology goes into TNF-alpha, the T helper 1, but not to go into too much specifics. The idea is it's called sarcoid when you have the granuloma formed, which is a sign of giant cells and chronic inflammation. And this is how a granuloma looks like, a big chunk of the collagen inside deposition, a lot of cells. And there's caseating granuloma and non-caseating granuloma that differentiates tuberculosis and chronic inflammatory diseases. So that's a distinction that the pathologist makes and the inflammation and deposition of these granulomas is what causes disease in sarcoidosis. The clinical presentation, as mentioned, it's mostly in the lung. So sarcoid rests mostly with the pulmonologist, even though it says 5% here, and this is the question of and a contention that lot of times it gets missed. And it's important to know that you're missing it. And if you look into certain data that show why we miss it, I'll talk about it in a minute. But there are clinical criteria. Whenever the criteria has a big list, we just don't know what the heck we're talking about. It just means like a bunch of people got together and agreed on this. And that shows the inability on knowing exactly how to pick up sarcoid. But I'm not going to go into the details of this, but there's major criteria, minor criteria when we should be suspecting sarcoid. Most importantly, I'll point out that a conduction abnormality, basal thinning of the ventricular septum, and then we're talking about gallium scan, but that's where Mouaz will show the utility of MRI and the utility of cardiac PET, which is actually emerged to be quite well established. The Heart Rhythm Society, in fact, has a better criteria in my mind, which clearly talks about histological diagnosis of an extracardiac sarcoid, and one or more of the following is present, which means that you have a heart block, unexplained reduced EF, unexplained VT, Mobitz type 2, patchy uptake on PET scan, gadolinium uptake on LGE, and positive gallium scan. So I think it's important to keep this in mind. And it's also pertinent to remember this was a study where out of 411 heart transplants done, there were a bunch of patients who were reported as non-ischemic cardiomyopathy, treated all their life, burned out hearts, and on explant. And we probably see that at least one a year of the transplants that we do. They come to us as end-stage heart failure, non-ischemic, and only after the heart comes out that it shows a sarcoid granuloma, which means that we have missed the diagnosis for a good period of 15, 20 years. By the time they reach us, we don't push the biopsy because the heart looks beat up and almost dead. But early on, if you recognize that, it makes a difference. Biopsy can still miss it because when we do a biopsy, we're going in and taking a small piece of the heart on the right side on the septum. But if you look at the scarring, it could be patchy anywhere, so it's easy to miss it. Outcomes are not good for sarcoidosis. If you look at a 5-year, this is older data, if you look at 5-10 year for sarcoidosis, a lot of it, you mean that you have diagnosed it as sarcoidosis. Despite diagnosis and treatment, there's a lag period here. By the time we diagnose, the heart's already beat up. So you're looking at a 50% close to survival at the end of 5-10 years. And if you pick it up early, maybe we can treat it better. Steroids make a difference if you pick it up early. In fact, your survival for steroids is higher than no steroids. And of course, there are other immune modulating medications. How to treat sarcoid, I think, to me, is a different discussion. The more important fact is you got to pick up the diagnosis first, then you can talk about treating it. So quickly, I'll set the stage for a 44-year-old female who had no past medical history, presented to the ER with 2 episodes of syncope in 1 week. First episode, she saw her doctor and reports normal EKG, and then reports tiredness, weakness for 6 months, some degree of shortness of breath, no chest pain, PND, orthopnea, or palpitations. Everything else is negative. Echo is normal. Blood pressure in the ER, heart rate is 43, respiratory rate of 18. And if you see, this is for sake of time, you see the P waves here march out. You have CQRS march out. That's a conduction block. It's a AV dissociation. And astutely, this is where a lot of times patients end up getting a pacemaker, treated, and sent home without asking the question, saying she's 43, why is she having this? So, and these are the labs. I think everything was benign. Echo looks normal. And if you look at the echo pictures, it's quite benign. Really, you won't pick up anything. And at the end of the day, it was an astute electrophysiologist who did not do an ICD as such, but in fact transferred over here for us to do an MRI to see if we need to diagnose the patient. And I'm going to move on with this and let Dr. Al-Mallah tell us about imaging and how the algorithms, what we need to use for it. Thanks, Mouaz.
So I'm standing between you and lunch. I'll try to make it easy and quick for a very difficult diagnosis. So this is actually a common diagnosis, not a common, it's a common scenario that we see, that people don't think of the diagnosis, and usually it's picked up very late. So there are cases where a patient will have a pacemaker or complete AV block at a young age, and it's unclear why. But sometimes it's not as easy as of diagnosis. And I can tell you that I used to practice in a hospital where we had 10,000 patients with an ICD code that were coded at one time for the sarcoidosis. And we started to do systematic screening of these patients using these imaging modalities. And we found out that many of them will have some evidence of cardiac or extrapulmonary sarcoidosis. So we had a multidisciplinary team of cardiologists, neurologists, ophthalmologists, pulmonologists, and electrophysiologists. And all of us were systematically looking at these patients. And we found that many of them will have either a visual problem or neurological involvement, but often we did find a lot of diseases. But our main concern was how to define cardiac sarcoidosis. If you saw the Japanese Ministry of Health criteria that Arvind just showed, it is very difficult to make a diagnosis, especially that is still relying on very old imaging modalities, still giving gallium, for example, which is not commonly used, very higher grade, while MRI and PET is not given as much. So I agree with Arvind that it's actually the new HRS criteria that we should be following more often. So there are 2 main imaging modalities that are currently being used in the current practice for diagnosis of cardiac sarcoid. I'll focus on them. And the first one is cardiac MRI. And in cardiac MRI, we do multiple types of images. So I'm not going to spend too much time on this, but I'll show you that we do look for some focal increase in thickness. We look for edema imaging, so we try to see if there is any edema in any focal part of the myocardium that's usually not following a coronary territory. And then we try to find out delayed enhancement. So after we give the gadolinium contrast, we wait for 10 minutes or 15 minutes and just go back and see if there is any area that's uptaking gadolinium and where gadolinium stick for longer time. And you can see here, this patient in the inferior wall, there are a couple of foci of increased gadolinium. Gadolinium is an agent that will go and stick in areas where there is fibrosis. So it will tell me that there is a fibrotic lesion there. which could be an inflammatory mechanism from before, but it may not always be sarcoidosis. So how do we make the diagnosis? So we say we raise the suspicion, but still the tissue diagnosis usually does not come from the heart. Because look here, I mean, the only part that I have is a small focus in the inferior wall, but in reality, if you go and do biopsy in the septum, which is mostly where it's done, they will miss it. And that's why from the series that you just saw from Cedars-Sinai, all these explanted heart, only 25% of them had a positive biopsy, because unless you do an LV biopsy guided by MRI and you go to this focal spot, then you're probably going to miss it. So this is what we see in MRI now. When these patients go to the degree of now heart transplant, when you see them in heart failure, so now they have like more of a burnout heart, and these are like easy to make a biopsy for, because now you have everywhere you have the delayed enhancement. Is so patchy, and this area has this patient will have almost always a lot of PVCs, a lot of VT runs, so these are not difficult to make that diagnosis at this stage. What we want to catch them is not when we reach this, when they reach this point. We want to catch them when they have only one focus, like in the previous case. So the other thing also, I told you that in MRI we could see multiple patterns of delayed enhancement in sarcoidosis. This is one paper out of Duke that looked at nearly 100 patients with cardiac sarcoidosis, and they classified what patterns we see with these patients. So some of it is just the simple subendocardial delayed enhancement. This is like a transmural in the anterior wall, so this is very much mimicking coronary artery disease. So in these patients, most often you need to have an anatomical study to rule out coronary artery disease. You could have a mid-wall inferolateral, primarily in the basal inferolateral wall, but also this is kind of where the most specific, and these are the sickest patients, where you have an epicardial in the you have an epicardial in the septum, but also with RV involvement. And sometimes you have this multiple patchy mid-wall delayed enhancement. In my clinical experience, these are the ones that are usually the sicker ones, and they have the complete Levy blocks and others with worsening cause. And with outcomes, we know that in these patients, we're not just detecting the delayed enhancement, it's for diagnostic purpose. Those patients from the Duke series, those who had delayed enhancement had worse event-free survival and also cardiac survival. So these are patients who will have worse outcome unless we have to intervene on them in this series. Now, the other modality that we are using for this nowadays is cardiac PET. And here I show you one patient from our practice that has both cardiac PET and cardiac MRI. So you can see here this patient has multiple areas of delayed enhancement. You can see this area, the one that I told you in the inferior wall. There is also involvement of the RV and the anterior wall of the RV. And you can see here how it correlates with PET. So with PET, we do two things. We do perfusion. So we try to see that there is area which is not getting enough blood because of the edema in there. So with the edema and inflammation, there is a perfusion defect. But also, we try to suppress the myocardium from uptaking inflammatories, from intaking fluorodeoxyglucose, which is the F18 or what is known as FTG. And we want the macrophages that are sitting in the non-caseating granuloma to take that FTG. So what I'm imaging is a perfusion defect that you see here, and then there is an equivalent delayed FTG uptake in this area, indicating that there are a lot of macrophages in this territory. It does correlate well with MRI, but not in every case. So here is another case where you see that there is a perfusion defect on this rubidium, where you see there is a perfusion defect in the anterior, anterolateral, and inferolateral wall, and in the same territory corresponding, there is an uptake. So it's like a mirror image. where there is an uptake actually in the second row, which is the FTG. And you can see here that there is uptake of FTG in that territory, telling me that this perfusion defect is associated with high metabolic activity cells sitting in there, which are usually the macrophages. So these, as you see here, this is the mirror image that we use to make our diagnosis. With cardiac PET, we not only diagnose just in the LV, but we can see it in the RV. As you see here, this is an MRI. You can see the RV uptake that we saw clearly also with the PET, so we can diagnose that. And also we can see if there is extra cardiac. So within our field of view, if we are imaging the lung or if we're imaging other parts and there is involvement, then we can see that because it's the same mechanism of these non-caseating granulomas and macrophages. So how do we use that? So right now, it's not clear which test to start with. There are always some groups recommendation, which easier. Now, obviously, if the patient has an ICD and your group doesn't perform MRI with ICDs, then you can start with PET. If the patient has renal failure and he cannot get gadolinium, you have to start with PET. But there are no clear guidelines, and most often right now we're ending up utilizing both of them to make a diagnosis because the results are not always 100% in agreement with that. And I'll show you some algorithms which one to start with, but at least here I'll show you a couple cases from the literature from the Brigham group showing a patient that does have a highly probable MRI, but then on the PET, there was some discrepancy. There is some uptake in the FTG, but it is not as good as you would like it to be if there is active disease. So, and on the other hand, you have a patient who has no delayed enhancement, nothing by MRI, but then there is some uptake in the FTG, which is, you can see here, sometimes the MRI is very positive, but the PET is not, or the other way around. So how do we put it all together? But before that, now we have even now new technology that's available in different hospitals, which is the PET-MR, which allows actually for acquiring the same image using the same machine. And if there will be any cardiac application of this machine, it will be in this type of patients, where you acquire PET and MRI in the same time and get fusion image. So you can see here that there is a small area of delayed enhancement, but it's lighting up big time on the PET, telling you that this area has a lot of metabolic activity in there. So how do we put it together? These are like couple algorithms that are suggested in the literature. You can potentially start with suspected cardiac sarcoid. In patients with suspected cardiac sarcoid, you can start with CMR. Now, if the CMR is negative, I wouldn't say don't do anything else, but it makes your likelihood less, because what CMR is telling you that there is a scar in a pattern of sarcoid. This means that the patient had history of involvement, which resulted in a small scar in there. So if a patient had surgery, if a patient scratched his hand, it will leave a scar in there. This is all what you get from the MRI. At this point, if there is delayed enhancement, then you are making sure that this patient is having had an episode which left a scar in there. But sometimes if the disease is active right now and hasn't resulted in the scar, as I showed you in the prior case, then you may not detect the scar and you may need to have to go to another test. So if you have high clinical suspicion, then you can go to cardiac PET. However, if the CMR is inconclusive or if the CMR is positive, does not tell you that the patient is active right now. All it told you, and when I told you when we did the screening of many of these patients, so they had sarcoidosis, but we just brought them and did an MRI on them, and many of them we found scars in their heart, but they were feeling fine. They were not having an arrhythmia or syncope. So all it told me that at one time after the disease activity kicked in their system, they had cardiac involvement. It could have been a year ago, or it could be 5 years ago. And in many of these patients, when we did cardiac PET, we did not find involvement at that time, active involvement. So if you have a positive CMR, it's better to go ahead and get a PET scan, because with the PET scan now, it will tell you if the disease is active at that time. If this delayed enhancement is so recent that it still have a lot of active macrophages in there. Now, how do you take it at that point for therapy? Now, this is like usually a multidisciplinary team. As I told you, we had a multidisciplinary team of rheumatologists, pulmonologists, and other organ involvement. And then you can do, from a cardiac standpoint, you will require immunosuppressive therapy, whether to put an ICD or not. In some patients, actually, who had very active disease and they were having a lot of runs. Initially, we wanted to try to immunosuppress them, so we gave them high doses of steroids, cyclophosphamide or methotrexate. Depends on the disease as per the recommendation of the rheumatologist. But sometimes you may have to end up giving them an ICD. It depends if you can cool them down or not. And then how to follow these patients up is another challenge. Now, once you put ICD, as you know, not every center is doing MRIs for these patients, or if they have a device which is not MRI compatible, then PET is probably going to have more advantage in there. And I'll show you here the same patient who we did PET, and you can see this patient had a lot of activity. So there is a lot of FTG uptake. Now, with immunosuppressive therapy, it didn't go away completely, but it has significantly decreased in there. Now, there were some hope that with MRI you can get similar thing with edema imaging. However, edema imaging has its challenges in MRI, and it may be non-specific. So PET is probably a better tool. Again, this is not evidence-based. This is more of an expert opinion. So the PET might be a better tool to go ahead and follow these patients once you start to make the diagnosis, start therapy, especially if they had the baseline PET, then you can follow it up and see the response to therapy. And this has been used clinically in the cases that I've had correlated with clinical improvement in the patient condition from arrhythmias and overall cardiac status. So with this, I'm going to stop and hand it back to Arf.
Thanks, Mouaz. I think we'll wrap up just with what happened with our case, and we can take some questions. But essentially, as expected, we ended up doing a RV biopsy at the time initially, with the MRI showing a suggestion of sarcoid that was completely negative. Electron microscopy was also negative, and at this time we did not have our PET scan. Actually, we still don't have our PET scanner ready. It'll be probably in the next few months. But she ended up getting an ICD with a negative biopsy, went home, but came back with the multiple VT episodes. And again, your suspicion now is higher. Your choices are either to treat her with a presumptive diagnosis of sarcoid, and you always look for sarcoidosis elsewhere. So they get a CT scan of the chest and see if there's any lymph nodes anywhere that you can biopsy, because a tissue diagnosis always helps. But she didn't have anything, and that's where if you look at autopsy studies, about 25% of prevalence in sarcoid patients. If you look at all sarcoid patients who end up dying, and there's an autopsy study showing the prevalence of sarcoid in the heart was up to 25%, which is underrepresented because you never pick it up. So we, in fact, ended up doing a robotic EP-guided biopsy. And, again, as Mouaz was saying, it's a multidisciplinary team. This was a first in man that we were able to do with a collaboration with EP. And you see over there robotic assistance with a bioptome. And in fact, the biopsy place that was guided by imaging and by EP guidance was on the LV outflow tract, where we would never imagine to biopsy. But this was an LV outflow tract biopsy, which is really what clinched the diagnosis. So this is a patient that even the free wall that the MRI showed them edema did not show it, but the LV outflow shows the granuloma up here. And essentially with this diagnosis, we were able to treat her, and all the VT went away, and essentially she's been stable after that. So with that, I think we want to impose on the fact that sarcoidosis might be missed in every patient who has some rhythm abnormalities and non-ischemic cardiomyopathy. Thank you.